Hello, I want to thank, first of all, the San Antonio Breast Cancer Organizing Committee for inviting me to discuss these posters today, and I want also to congratulate the authors for their works and for sending me the posters to prepare the session. Here are my disclosures, and here the posters we'll be discussing in the next 15 minutes. We'll start with two abstracts that evaluate neoadjuvant approaches with two different tyrosine kinase inhibitors, tucatinib and pyrotinib, and one abstract that provides preclinical information regarding acquired resistance to tucatinib. Let's start with the first abstract presented by Dr. Potter and co-authors. Tucatinib is a potent and selective anti-HER2 TKI, and here they report the safety and efficacy of adding neoadjuvant tucatinib combined with paclitaxel, pertuzumab, and trastuzumab in a planned safety run-in of the I-SPY2 trial for HER2-positive patients. Longitudinal MRI volume reduction from baseline prior to AC and surgery is used to predict the pathological complete response for individual patients until their PCR data becomes available. The primary endpoint of the trial was PCR, with the goal to identify and graduate regimens that have at least 85% predicted probability of success in a 300-patient phase 3 neoadjuvant trial. The initial tucatinib dose tested was 300 milligrams BID. After the enrollment of the first 8 patients, there were 3 patients with grade 3 AST elevations and 2 patients with grade 3 diarrhea. Tucatinib dose was lowered while level, and an adaptive strategy was also tested with similar adverse events. Importantly, no patients met criteria for high-low syndrome. Safety data were reviewed after the enrollment of 20 patients, and the arm was suspended because of similar adverse events, regardless of tucatinib dose reduction or schedule used. Regarding efficacy, the assessment of the MRI during treatment identified 15 of 17 patients treated with tucatinib that had more than 80% reduction of tumor volume by 12 weeks, being most of them on or below the TPH control arm prior to AC. Authors concluded that the addition of tucatinib to paclitaxel quadruple-containing regimen resulted in grade 3/4 unacceptable but reversible toxicities, despite those reductions that made the combination considered not feasible. From the efficacy point of view, a greater than 80% decline in tumor volume at 12 weeks was reported in 86% of patients. Let's move to the second trial presented in this session. The FEDERA trial is a multi-center, double-blind, randomized, and placebo-controlled phase 3 study that recruited patients in 17 sites in China. Pyrotinib is an irreversible pan-HER2 inhibitor targeting EGFR, HER2, and HER4. 355 patients with confirmed early or locally advanced HER2-positive breast cancer were randomized to receive trastuzumab, docetaxel at the 3-weekly standard doses, plus pyrotinib or placebo at 400 milligrams daily at continuous dose for 4 cycles. Primary endpoint of the trial was total pathological complete response, assessed by central independent review on the surgery specimen. Stratification factors were tumor size and hormone receptor status. All patients received as adjuvant therapy 3 cycles of FEC, followed by anti-cancer treatment at physician's discretion in accordance with clinical practice guidelines. Baseline demographic characteristics and demographics is summarized in this table. Patients had a median age of 50 years, and more than 70% of patients in both arms had nodal involvement at inclusion. The trial met its primary endpoint as a statistically significant increase in total pathological complete response was observed from 22 to 41% when pyrotinib was added to docetaxel and trastuzumab. The toxicity profile of the regimen is summarized in this slide. 71% of patients in the pyrotinib group and 37% in the placebo group experienced adverse events of grade 3 or 4, with diarrhea being the most common one. No primary prophylaxis with any treatment was mandatory, and 38% of patients experienced grade 3 diarrhea during the first cycle, with a progressive decrease in this percentage in subsequent cycles. Median duration per grade 3 episode was 2 days. Despite that, the compliance of the overall treatment was maintained over 90% in both treatment arms. Authors concluded that the addition of pyrotinib to docetaxel and trastuzumab in the neoadjuvant setting led to a statistically significant and clinically meaningful improvement in pathological complete response rate, and consider acceptable and manageable the toxicity profile of the regimen, with the claim that these findings support the combination as a new neoadjuvant treatment option in this patient population. But as for now, and to contextualize the results we've reviewed in this first part of the presentation, the standard of care for patients with HER2-positive tumors larger than 2 centimeters considered suitable for neoadjuvant treatment is a dual blockade with pertuzumab, trastuzumab, and taxane, with or without anthracyclines or carboplatin, based on the Neosphere, Trifina, and TRAIN2 trials. Even taking into account the different drugs and number of cycles used, the PCR rate that we may expect in the clinic using these regimens is between 40 to 68%, assuming grade 3 or higher diarrhea of 17% and 5% of liver function test alteration in the worst case scenario when using pertuzumab in the dual blockade strategy. Previous attempts to integrate in the neoadjuvant setting other TKIs have been reported without success bringing these treatment regimens into the clinic. In this slide, you have depicted the trial design for the NeoAlto and CALGIBIL trial testing lapatinib and the I-SPY2 and NSABP FB7 trial testing neratinib. Interestingly, the PCR rates in all the trials are around 50%, not far from what we can expect with dual blockade with pertuzumab. But grade 3 diarrhea exceeding 20% in all cases and grade 3 liver toxicity around 10 to 50%, with in some trials patients fulfilling criteria for high-low syndrome, have led to the fact that these regimens are not being used in clinical practice. The two trials presented today report similar efficacy results using pyrotinib. Diarrhea reported for both trials are above 25%, and liver toxicity for tucatinib in the quadruple arm is clearly above previous percentages, and in the curative disease setting, the balance between toxicity and efficacy really makes the difference. In the metastatic setting, tyrosine kinase inhibitors have achieved regulatory approvals, and their use in clinical practice is extended. Efficacy results, in this case measured by PFS, are not comparable due to the population included in each trial and previous treatment received. Of note, and focusing our attention on the toxicity of these regimens, the highest grade 3 or higher diarrhea was reported for the regimen with pyrotinib in the Phoebe trial. But it must be noted that primary prophylaxis with antidiarrheal treatment was not mandatory in this trial. It seems that diarrhea appears more frequently with irreversible and non-selective TKIs, probably because of their potency and EGFR inhibition. In any case, in the context of early or advanced disease, an effort must be made to minimize this gastrointestinal toxicity. With neratinib, a great effort has been made to optimize the management of diarrhea in the control study in the context of extended adjuvant therapy. It seems that with the use of primary prophylaxis with loperamide, colestipol, or budesonide, as well as dose escalation regimens, the frequency of occurrence of this toxicity can be significantly reduced. The application of these strategies to mitigate diarrhea seems to be an excellent option to improve the quality of life of patients using these drugs in our clinical practice, and this may be considered for further development also with pyrotinib. Onset of TKI hepatotoxicity is usually within the first 2 months of initiating treatment, but may be delayed and is usually reversible. In the case of the tucatinib study, it appears that the liver toxicity observed with the addition of tucatinib to pertuzumab, trastuzumab, and paclitaxel clearly exceeds the reported in studies of early or metastatic disease with doublets or triplets, and an adaptive approach does not seem to work to prevent this toxicity, where may have been drug-to-drug interactions rather than a need for adaptation of tucatinib dose or schedule alone. Other ongoing trials, as the Muntener-2 for patients with gastric adenocarcinoma, will give us additional information on these potential interactions. So in conclusion for these two posters, From the iSpy2 trial testing tucatinib, PCR is not yet reported, and importantly for a neoadjuvant regimen, the impact that the toxicity observed may have on dose intensity, not only for tucatinib but also for the whole regimen, will be reported in detail in a later stage. The effort made with tucatinib dose reductions or escalating dose in an adaptive dose was unfortunately unsuccessful to make the regimen tolerable, and it has to be considered how far to escalate and whether a 4-drug regimen is the optimal strategy or not. The current goal for tucatinib with the triplet with capecitabine and trastuzumab well positioned in the metastatic setting is the combination with other drugs and the transition to the early setting. Phase 1 trials with a combination of ADCs such as TDM1 or TTXD determine no need for dose reductions for tucatinib. The balance between toxicity and efficacy that will be reported in future trials from the HER2 CLIMB study in the metastatic setting, the COMPASS-2 trial for patients with residual disease in the early setting, or the HER2 CLIMB-4 trial in combination with TTXD will be crucial at this point to position the drug in new potential scenarios. For the FEDRA trial, is pending to be reported detailed impact of toxicity in dose delays, dose reductions, and discontinuations. Has to be recognized the major effort done to carry out a phase 3 trial in the neoadjuvant setting, but with the limitation of having a suboptimal comparison arm as it does not include pertuzumab. And as future challenges for these drugs, we'll need to see results of this drug in populations beyond China and patients treated with the standard of care anti-HER2 therapies in the rest of the world. Let's move now to the third poster focused in another important topic, mechanisms of resistance. In these posters, authors tried to elucidate mechanisms of resistance to tucatinib by using an acquired resistant model in vitro using a widely known cell line. To address this question, authors performed genomic, transcriptomic, and proteomic analysis to see differences between sensitive and resistant cells to tucatinib. In contrast to lapatinib-resistant cells, which may acquire HER2 mutations, and neratinib-resistant cells that may acquire PI3K pathogenic mutations, as previously reported, tucatinib-resistant cells, at least in these two clones presented, showed amplification in EGFR. The amplification led to the clear hyperactivation of the activity of EGFR by means of phospho-EGFR. In addition, these cells exhibited also a reactivation of the HER2 signaling and an increase in phosphorylation in HER2, HER3, and S6. In order to prove if EGFR activity is the cause of the activation of the pathway, authors use an EGFR inhibitor, gefitinib, and they see that using this inhibitor alone or in combination with tucatinib, there is a suppression in phosphorylations on the HER2 axis, meaning that tucatinib-resistant cells are hypersensitive and finding a vulnerability on these cells. They also showed that tucatinib-resistant cells are sensitive to pan-HER2 inhibitors as neratinib, pirotostinib, or poziotinib, in addition to TDM1, which opens the avenue for the treatment of refractory patients to tucatinib with these pan-HER2 inhibitors. The authors summarize the results and share potential clinical implications that their findings may have in the clinic when considering the sequencing of treatments at progression of the disease, as you can see in the cartoon shown in this slide. The poster is interesting and builds the rationale to use EGFR inhibitors or pan-HER2 inhibitors when appears an acquired resistance to tucatinib. The data is convincing and reflect what they state. However, there are some limitations that may be taken into consideration in order to strengthen this preliminary data. First of all, this is just one model of resistance. Authors may consider to generate other resistant models because maybe the causality established is just correct for this model. Second, data on the proposed resistance mechanism tested in vivo models would greatly reinforce the conclusions drawn, and PDX experiments would remarkably improve the translational implications of their findings. Third, the amplification of EGFR only occurs in acquired resistance, or there are intrinsic resistant patients to tucatinib that bear EGFR amplification. This can be addressed through genomic data, and I'm sure that the in-depth characterization that authors mention that is ongoing will help to elucidate this question. And fourth, authors suggest that there are heterodimerization between EGFR and HER2 in resistant models to tucatinib, but they do not demonstrate that. This is quite easy to address and have important biological implications in the rationale of subsequent therapies to be used at resistance. In conclusion, this work launches a very interesting and plausible hypothesis taking into account the selective mechanism of action of tucatinib against HER2 receptor. We must continue working in this line of translational research, not only with cell lines, but also with animal models in which resistance may be generated in the lab or implanting samples from patients with acquired resistance in the clinic, because this is the way to rationally sequence all the treatments that are coming to the clinic for our HER2-positive metastatic patients. And with that, I want to thank all the breast cancer team at Vall d'Hebron, especially Santiago Escrivá and Mafalda Oliveira, and Enrique Javier Arenas from our lab, helping me to prepare this session. Thank you for your attention.